Hello nurses, this is Kevin with Nursing KAMP.com, and these are my scribble notes on nursing in the NCLEX. Today's focus is going to be on alpha medications and these sticky notes on alpha-1 agonists, to include Levophed and Neo. Okay, let's get going. Alright, so when we're talking about Levophed and Neo, the reason they're together is because they are both alpha meds. And what I mean by alpha meds are the patient who receives alpha meds. Alpha is away from the heart. And when you take the A and you flip it upside down, this V means it vasoconstricts. And that's an important concept when we're trying to correct blood pressure, especially in cardiogenic shock, septic shock, and signs and symptoms of hypotension. So when you have a alpha medication or alpha squeeze, what happens is that you need a central line for that administration because it is caustic to the veins, and infiltration would require immediate attention because of the tissue will become damaged from it. So that's why the preferred method is through a central line. So these patients will be generally in the ICU receiving these medications. Some things that we look at with the alpha medications is the concept. And that concept is that you fill a pump before you squeeze. And what I mean by that is that if you're going to squeeze vasoconstriction, a patient, and they might be dry. And how do I know they're dry? Well, their CVP might be less than 4. Their PAWP, or their wedge pressure, might be less than 8. See my hemodynamics lecture on that. So we assess this hemodynamic status, and then we will institute first increased fluids. So like in sepsis, what happens is that the person, prior to coming into with sepsis, they might be filled in their vessels. But in the presence of lactic acid, these vessels start to dilate. And when they dilate, like in this, the fluid volume goes down. So the rule is that we fill them up. We fill before we squeeze. So we fill them up with fluids, 4 to 6 liters, and this is followed by policy and joint commission. All right. Then, once we fill them up, we will then squeeze the patient. And what I mean by squeeze is vasoconstrict. And what will happen is that when we squeeze the vasculature, that volume will go back to the heart. And if the heart is working fine, which it would be in septic shock, it's able to handle the volume, and will have an increase of cardiac output and an increase of blood pressure. And we monitor their mean arterial pressure. And that needs to be greater than 60 to 65. Okay, some other things about this medication. Well, there is a difference between Levophed and Neo. Though they're both alpha medications, Levophed has a inotropic interaction with the heart. Inotropic, see my lectures on inotropic, chronotropic, and dromotropic. Inotropic is a class of medication that I know the force. And what it means is I know the force of contraction. It means that it's going to pump the heart. That's very specific for Levophed. In the past, we used to call it Levophed, leave him dead, because a patient who receives Levophed, it's acute. And it's kind of, we really need to put this is our last ditch effort. This is the big guns. And this is what we need to put on them so that we can increase the blood pressure and treat sepsis and support the body for perfusion. And see my sepsis lecture where I cover that. Why? Next thing is that, so Levophed is a inotropic and a alpha medication for alpha squeeze. But Neo is only alpha, period. So it's the ideal medication when we require squeeze only. We don't want to mess with the heart. We just need to treat the blood pressure. And how we do that is that we put them on Neo, and that will gently squeeze them, and it doesn't affect the heart, only by volume. Okay, so some things to think about with Neo and Levophed is MAO inhibitors. We'd monitor for bradycardia, and AV blocks. Blocks are a problem, especially with Neo. Also, we'll be monitoring the heart for ischemia. And ischemia in an ECG, and this would be in lead 2. We would monitor in lead 2 because that is the ventricle, the left ventricle. We'll be looking at this part of the left ventricle in lead 2, and it should look like this. But with ischemia, we see ST depression, and that's acute. ST depression generally will happen before ST elevation. So ST depression means ischemia. All right, let's run through our AWALS. And AWALS is a method I use to evaluate medications. AWALS. All right, is it acute? Well, they're both acute. How do they work? Well, they work on alpha, and what they do is they constrict. When do we hold it? Like other alpha meds, we MAO, AO inhibitors. Patient with sulfite sensitivities. We hold it for bradycardia, AV blocks, and any signs of ischemia, like ST depression. What's the assessment? Well, they'll be on a cardiac monitor in lead 2. They'll have a triple lumen, and we're going to monitor vasculature. And what we're monitoring is peripheral pulses. So we're not squeezing them so much that we need a Doppler to feel their pulses. Some other assessments, we monitor the site. We make sure that's in a triple lumen and not on the side. Any labs associated with it. Mainly hemodynamics, like your CVP and your wedge pressure. And that will tell you what is the fluid volume. Anything with eating, they'll probably generally be NPO or on TPN. So what stands out? Well, what stands out is these are septic meds. Septic critical IV drips that are acute and used in the ICU. They're for blood pressure and shock. So these are your shock meds: spinal shock, septic shock, cardiogenic shock, or hypotensive episodes with low blood pressure. But remember, fill the pump before you squeeze, and never ever hang Levophed or Neo unless you know hemodynamic status and fluid status. Well, that's about it. My name's Nursing Camp. You can find me on social media. Social media, Instagram, Facebook, Pinterest, and Etsy, Nursing Camp, and also on nursingkamp.com. These are my sticky notes, and we will see you next time.